Oh my God, there's no sound. I talked so long. First, my stream died on the first three questions, and then I did the next three questions, or two questions, and I was explaining my thought process for all of them, and I didn't have the microphone turned on for some reason, which is weird. The microphone was turned on. I don't remember muting it. I don't know what happened. So that is very unfortunate because I feel like I explained so much of why I was thinking all these different answers for these previous questions. But yeah, that's unlucky. But thanks for pointing that out, Sardash. Why don't we just start off? Let me move you over here. Let's just start off with this question again. This is question number 6. So I'll start reading this from the beginning again. A 56-year-old man is evaluated in the ICU for hypotension. Which of the following is the most appropriate treatment? It's TPA, apixaban, heparin, or low molecular weight heparin. And this guy, they basically talk about how he has a large PE. And I was talking about how with this statement here, they're basically saying that he is high risk PE or a massive PE because he's hemodynamically unstable. Hey, KTG, what's up? So there's only one answer here, and that's definitive treatment with TPA, which is the clot buster to like break up that whole thing. But I was looking into this physical exam a little bit. So his cardiac exam reveals a 2 out of 6 systolic murmur above the left lower sternal border. So that's most likely referring to tricuspid regurgitation. Basically, left lower sternal border matches up with the tricuspid valve, and then this patient has a massive PE, which is going to be causing very high pressures in his pulmonary vasculature and causing kind of, when the heart's squeezing, it's going to be regurgitating back through that tricuspid valve. And then the second heart sound is persistently split, which is interesting because splitting of the heart sounds is something I always have to look up again. I'm trying to practice doing it more and more often so that I remember more frequently. So I just remember it a little better. But basically, the second heart sound, you have both the aortic valve and the pulmonary valve. And so because the aortic valve has higher pressure, it will close first. And then the pulmonary valve is a lower pressure system, so it closes second. So it's aortic, pulmonary, aortic, pulmonary. But when you breathe in, you're actually increasing. So when you're doing inspiration, you're actually increasing the pressure in the pulmonary system, which causes the pulmonary valve to close earlier. And so you lose that splitting on your auscultation, basically, on your S2 heart sound. So that's physiologic splitting. And so I should have a Anki card on that. So physiologic splitting. There's also paradoxical splitting. So splitting. So splitting disappears on inspiration is paradoxical. Oh, so I still had it backwards for some reason. Let's see. So normal splitting, you have, so normally, let's see. I can't believe I keep messing this up. Normal splitting, you have inspiration, which delays closure of the pulmonic valve. Paradoxical splitting. Okay, but yeah, I don't know. If you guys can answer this, I definitely have to think about this later. I don't want to take up too much of your guys' time on the stream for this, but splitting is something that I always had to think about, like to remember which one splits first and whatever. My thought was that the aortic valve closes earlier because it's higher pressure, right? And then pulmonary valve, I would have assumed it closes faster when you inspire. So anyways, let's just give this person TPA and move on to the next question. Oh, there's some weird studies that they're citing in here. According to the Amplify study, apixaban is an equivalent option to conventional heparin therapy for initial treatment of PE. Sure, that's fine. It's just as you explained. It disappears on inspiration because of the blood influx on the right side on inspiration. Okay. So that causes your pulmonary valve to close. So when you inspire, it delays the pulmonary valve from closing because there's more volume of blood, right? So that's why the pulmonary valve takes longer to close. Yeah. Physiologic split is on expiration. Yeah, that makes sense. For paradoxical splitting, these are heard in conditions that delay aortic valve closure. So this one, you have basically when you inspire, it causes the pulmonic valve to close later. So on inspiration, you have the disappearance of the splitting. That makes sense. So just basically when you breathe in or you inspire, you're bringing in more blood into the right side of the heart, and that makes the pulmonic valve close more in a delayed fashion. So that makes sense. So physiologic splitting is when you have splitting on expiration, and then it goes away on inspiration. All right. Always a good review to look over that stuff again. All right, let's move on to question number 7. So far, we have a 100% correct rate on this 20-question test, so we'll see if we can maintain that. A 76-year-old woman arrives for follow-up consultation regarding a recent diagnosis of essential thrombocythemia. A bone marrow biopsy shows hypercellularity with increased numbers of enlarged megakaryocytes. Which of the following is the most appropriate management? So add clopidogrel, add hydroxyurea, change aspirin to clopidogrel, and perform platelet pheresis. So in this case, it depends on kind of what, like if somebody has essential thrombocythemia, sometimes we treat them with aspirin. But if it's really, really bad, I believe we add hydroxyurea, which will just basically suppress the bone marrow. She was hospitalized 5 days ago for a stroke. Evaluation at that time showed a platelet count of 660. Results of iron studies, JAK2 mutation testing, and PCR for BCR-ABL were normal. And no secondary cause of thrombocythemia was found. Medical history is notable for type 2 diabetes and dyslipidemia. Medications are low-dose aspirin, metformin, and atorvastatin. The spleen tip is palpable, slight hemiparesis. It's interesting because after a stroke, a lot of times we give them dual antiplatelet therapy for like 3 weeks. And they only gave her aspirin alone. That being said, if we're going to treat for essential thrombocythemia, then we would probably add hydroxyurea, and then the bone marrow biopsy kind of shows that she's got this kind of hyperproduction going on. So I'm going to go with add hydroxyurea, but I'm curious as to why she was not on dual antiplatelet therapy for a stroke. All right, so keeping that record alive, the patient has essential thrombocythemia, should be treated with hydroxyurea. So first step is to rule out secondary elevation. JAK2 mutation testing is positive in only 60% of patients with essential thrombocythemia. And I think I've actually written that on a card somewhere. Actually, this is my card. Can a JAK2 myeloproliferative neoplasm present without elevated hemoglobin or platelets? Yes. So that's a question I remember getting wrong in the past as well. So let's see. 10 to 15% of patients will have negative results for all 3 mutations. However, she had hypercellularity. Platelet pheresis may be indicated in patients who have markedly elevated platelet counts, usually greater than 1 million, and acute hemorrhage. And changing antiplatelet from aspirin to clopidogrel would not address the need for platelet lowering therapy. Yeah, well, I'm still not totally sure why they weren't placed on dual antiplatelet therapy, but sounds like hydroxyurea was the right answer anyways, so let's keep it up. A 74-year-old man is evaluated for a 4-month history of increasing fatigue. A colonoscopy performed to the ileocecal valve identified a fungating mass at the hepatic flexure. A biopsy specimen shows moderately differentiated invasive adenocarcinoma. So this question is basically, what should we do next for staging of colon cancer? So in this case, we have CT colonography, contrast CT, chest, abdomen, pelvis, liver, MRI scan, and whole body PET scan. The two options I think that are reasonable here are going to be the whole body CT scan and whole body PET scan. But I actually have a card on this, and so I'm going to go with the CT, which is 83%. And so this is a card that I made in the past. But what testing should a patient undergo after being diagnosed with colon cancer on screening colonoscopy? CT, chest, abdomen, pelvis. First thing to do is to check staging. You need to check for metastases. No real indication for PET CT in most scenarios. So you can see that a lot of people picked the PET CT, which was the second one that I was going to go for. But now this is kind of reminding me that the PET CT is not indicated, rather than instead just getting that CT, chest, abdomen, pelvis. CT imaging with contrast provides the most reliable means of detecting the presence of metastatic disease to lungs, liver, intra-abdominal lymph nodes, and peritoneum. CT is also useful in planning appropriate therapy. Patients with local or local regional rectal cancer require further preoperative staging with ultrasonography or pelvic MRI. CT colonography would not add to any information. It is an acceptable alternative to a screening colonoscopy for healthy individuals at low risk. Liver MRI is a sensitive tool to identify liver metastases, but this is reserved for patients with suspicious but not diagnostic lesions on CT. And national guidelines specifically do not recommend PET CT scans for either preoperative staging or for postoperative surveillance. PET CT scans have a higher false positive rate and false negative rates than is often appreciated, and has higher false positive and false negative rate than is often appreciated. So I like to add some various details to my Anki cards as we go through things and as I learn new things. But in general, I try to only make one card for each question that I get wrong. I try to make one question from that, question that I got wrong, trying to get that key point that caused me to miss that question. So that's generally my approach to making cards. A nice nail question here. So a 25-year-old woman is evaluated for finger pain that began approximately 6 weeks ago. She works as a hairdresser. And then which of the following is the most likely cause of this patient's tender finger lesion? Acute paronychia, chronic paronychia, onychomycosis, and psoriasis. Paronychia usually is going to be a lot more hot, inflamed, swollen. I haven't really heard of chronic paronychia. I suppose that could be something. Onychomycosis, usually going to get that yellow-green discoloration. It's usually seen on the feet, the toes more. Psoriasis, maybe if there's some nail pitting or something. But let's see. On physical exam, vitals are normal. Skin findings reveal ragged cuticles on most of her digits. On the third digit of the left hand, the nail fold is tender. Skin and nail findings are shown. It began 6 weeks ago. I don't think it's acute paronychia. It's 6 weeks old at this point, and it's a lot more angry looking than this. I don't know what chronic paronychia is, but I'm kind of inclined towards picking that one. This very well could be honestly, this looks like kind of my fingers with eczema sometimes, but usually eczema doesn't cut, eczema and psoriasis obviously are not the same, but usually these don't cause tenderness. But I think psoriasis could definitely be a finding here. Psoriasis causes so many nail findings. And I don't think it's onychomycosis. I'm just going to go with chronic paronychia, but my gut actually is kind of telling me that psoriasis is the answer here because I've never heard of chronic paronychia. Okay, we're actually right. Chronic paronychia. Present for 6 weeks or more and affects multiple fingers. Typical manifestations include red, swollen, and tender nail folds that lack a cuticle, ridging and dystrophy of the nail plate. Candida is often isolated, and chronic irritation from water or chemical contact is the primary cause. An important component appears to be an eczematous process, which explains why patients with chronic paronychia respond better to topical glucocorticoid than topical antifungal therapy. Yeah, and honestly, that's what I was saying. This looks like sometimes my fingers get a little get some eczema on them. Actually, since I left the hospital, they're getting better. But this looks like eczema to me. Acute paronychia is usually one nail. It's much more angry. Onychomycosis, usually in diabetic patients, usually becomes yellow and lifted. And I don't think I've ever really seen it on fingernails, usually on toenails. Nail changes occur in about 75% of people with psoriasis, usually hyperkeratosis, thickening and discoloration, and pitting and ridging. All right, question number 10. We still got that 100% answer rate, so let's try and keep it up. A 65-year-old woman is evaluated for watery, non-bloody diarrhea of 8 months duration. Chronic diarrhea. Lab studies show hemoglobin, albumin, IgA, and TTG IgA levels to be within normal limits. Which of the following is the most likely diagnosis? So giardia for 8 months, probably not. Microscopic colitis, yeah, that sounds pretty reasonable. Small intestinal bacterial overgrowth, ulcerative colitis, not so much. Microscopic colitis, these middle-aged, sort of elderly women with chronic diarrhea and kind of just negative workups, this kind of screams microscopic colitis. Small intestinal bacterial overgrowth, if she had a history of surgeries or something like that. Ulcerative colitis, IBD does have this bimodal distribution, but generally she's going to have more systemic symptoms. She's going to have fevers. She's going to have bloody stools, hematochezia. So she reports up to 6 bowel movements per day with nocturnal awakenings. So it's telling us it's a secretory process rather than an osmotic process. And that again goes with microscopic colitis. No abdominal pain, bloating, flatulence, or weight loss. The fact that there's no weight loss, I think, is reassuring against inflammatory bowel disease. Last screening, colonoscopy at age 60 was normal. No family history. Has osteoarthritis with ibuprofen, which may be a risk factor for microscopic colitis. I'm not actually sure. And the patient is not exposed to children and has no recent travel history or engagement in outdoor recreational activities. So initial thoughts were definitely microscopic colitis on this one, and my secondary thoughts are also microscopic colitis. Small intestinal bacterial overgrowth really would have to give you a history of some kind of surgery, in my opinion. So microscopic colitis is the underlying cause in 10 to 15% of patients with chronic watery diarrhea. In contrast to IBD, this is more common in older people and does not cause endoscopically visible inflammation. There are 2 subtypes, lymphocytic and collagenous. And you take random biopsies. And yeah, in some patients, certain medications such as NSAIDs and PPIs have been implicated as causative agents. Microscopic colitis is also associated with other autoimmune diseases such as diabetes mellitus and psoriasis. The association with celiac disease is particularly important because the conditions are similar. Giardia, just not really there. So yeah, gastric bypass surgery is an increasingly common cause of SIBO. Other things would be just disruption of the normal flow of the bowel. The absence of malabsorption symptoms also makes this diagnosis less likely. So that isn't something else to take note of as well. And my stream is still running. Just wanted to make sure. So ulcerative colitis, again, you would see rectum, hematochezia, abdominal discomfort, fever, weight loss, things like that. So question 11, a 27-year-old woman is evaluated for proteinuria identified on urinalysis performed for a life insurance examination. I love having some urine studies to take a look at. And proteinuria in a young person, there's a big potential that this is going to be something on orthostatic proteinuria, which is just a benign thing in young people. So creatinine is normal. A1C is pre-diabetic range. Albumin's normal. Urinalysis has 3+ protein, and urine protein creatinine ratio is 2100, 2.1 grams. So it's definitely dropping a lot of protein. But the albumin's normal, which is reassuring. Kidney ultrasound is normal. And which of the following is most likely diagnosis? Okay, so that orthostatic proteinuria is not here, which I will show you guys. There's this orthostatic proteinuria benign cause of proteinuria in adolescents. It's a mild proteinuria with no significant other renal abnormalities, diagnosed by split 24-hour urine collection showing elevated daytime but normal nighttime protein excretion rates. So I guess she's 27. She's a little bit older than the typical patient population for that disease. So diabetic nephropathy, very, very unlikely for her. She's pre-diabetic. It's going to take a lot longer for diabetic nephropathy to happen. Lipoprotein glomerulopathy, I'm not actually 100% sure if I know what that one is. The minimal change disease. Minimal change disease is a possibility, but minimal change disease, generally the key feature with that is very, very rapid onset of edema, and she has not had any symptoms. And then secondary focal segmental glomerulosclerosis, secondary FSGS. Does she have anything that could, predispose her to that? She does have elevated BMI of 37. I don't know what this lipoprotein glomerulopathy, it might be this, but I don't think it's diabetic based on the what do you call it? The severity of her diabetes. Minimal change disease, it's hard to tell. I mean, you need a biopsy to see that there's minimal change, right? But seems less likely, just given that from what I've seen, minimal change disease usually presents with rapid accumulation of edema. And again, I don't know what this lipoprotein is. Secondary FSGS is definitely there, but would have been helpful if they gave us a history of hepatitis or drug use or HIV or something like that. But it can happen a lot in patients with who are obese, because they have this kind of hyperfiltration that's going on, which can lead to secondary FSGS. And so we see secondary FSGS in patients who are African American, who are overweight, obese. These are some of the risk factors for that. So I'm going to go with this, mainly because I don't know what this lipoprotein glomerulopathy is. And that's correct. And you can see this one went all the way down the board where nobody really knew what was going on this one. And I agree, kid, creatinine would be higher in diabetic nephropathy, generally speaking. So secondary FSGS. Secondary FSGS is the most common form of nephrotic syndrome in Black people. In the United States, FSGS currently accounts for up to 40% of idiopathic nephrotic syndromes in adults. The pathogenesis of FSGS stems from podocyte injury due to immunologic, genetic, and/or hyperfiltration causes, which is basically what's going on for this patient. A large and growing proportion of FSGS is from hyperfiltration injury in the setting of relatively reduced renal mass. The overworking of the glomerulus causes podocyte injury, blah, 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 but classically seen in patients with obesity. Let's see. So she has two risk factors for secondary form of FSGS, obesity and history of premature birth. Wow, they even mentioned the history of premature birth. That's they did some real deep chart digging on this patient. Yeah, and then secondary FSGS lesion with proteinuria and no associated clinical findings. Remember, because let me see, because typically you're gonna have more symptoms with minimal change disease. Yeah, so edema here, full nephrotic syndrome. So much, much more severe symptoms. Lipoprotein glomerulopathy is a rare kidney disease with moderate to severe proteinuria, glomerular capillary dilation by lipoprotein thrombi. Less than 100 cases have been reported in medical literature, nearly all of which are East Asian countries. So yeah, that's now I feel a little bit more reassured about why I've never heard of this condition. All right, question number 12, you guys, we're on a roll. A 79-year-old patient is evaluated for hyperkalemia. Hey, Ahmed, thanks for joining in. I'm really liking, I found that I do kind of gravitate to these kind of nephrology questions. They're pretty fun, like electrolyte abnormalities, protein in the urine, looking at the urinalysis. It is very, very interesting. So she was admitted to the surgical ICU after having a partial colectomy with ruptured diverticulum with peritonitis. Creatinine is 3.6 with a baseline of 2. Potassium 142, potassium 7.1, chloride 102, bicarb 17, pH 7.25, urine sediment brown granular cast. So she's got some ATN going on. She's got peaked T waves with QRS of 140. In addition to IV calcium insulin dextrose, which of the following is the most appropriate treatment? So this is kind of a question of, yeah, this is basically, I'm thinking of doing dialysis for this patient, because we've got multiple ways to remove potassium here. So Lasix is good, but this patient's got like an AKI and potentially is not peeing very much. Yeah, she's oliguric. So Lasix cannot eliminate that. Then we talk about Kxalate, sodium polystyrene sulfonamate, enema, but like this person just had like a ruptured diverticulum with peritonitis. Are you going to stick some like bowel regimen in her? Probably not. And that's going to work pretty slowly. She's already got EKG changes. Sodium bicarb is only a temporizing measure, so that only lasts for like 1 to 4 hours. You're not going to do that. And then the question is, are you going to do continuous renal replacement therapy or continuous dialysis, or are you going to do hemodialysis? Now, hemodialysis is going to have better control of your electrolytes. You're going to get to, correct that more quickly. But the continuous renal replacement therapy is going to be better for hemodynamically unstable patients, say the blood pressure is low. Yeah, D, Ahmed, the pH is low, which is definitely contributing to the potassium being high. But because it's just such a temporizing measure, we need some way to fully eliminate the potassium here. So let's see. She was treated with IV fluids, antibiotics, and vasopressors. She is oliguric with urine output of less than 5. She is off vasopressors. So these are all signs that she does not need continuous dialysis or continuous renal replacement. Significant for hypertension, stage 4 CKD. Outpatient medications are amlodipine, irbesartan, and furosemide. She's currently on morphine, propofol, cefotaxime, and metronidazole. Patient is intubated and ventilated. She's febrile. She is anasarchic. She's got okay blood pressure, enough where I think she could probably tolerate dialysis. So I'm going to go with hemodialysis, and that is the correct answer. So intermittent hemodialysis is the most efficient way to correct this patient's hyperkalemia. Continuous renal replacement therapy is good if they were hemodynamically unstable, like I mentioned, but it's much, much slower and cannot clear potassium as quickly. Furosemide would be helpful, but the patient is anuric with acute tubular necrosis going on. Sodium bicarb is transient and ineffective in end-stage kidney disease, a severe AKI. And then the Kxalate is actually known to have this like bowel necrosis side effect. So if you've already got all this like surgeries and stuff going on, you do not want to give them Kxalate for that reason. All right, let's keep it up, you guys. So question number 13, we got 8 more questions to go. A 28-year-old woman is evaluated for 2 weeks of intense rectal pain. Watching and attending work through questions is such a privilege. Yeah, I'm glad you like this. It's fun. It's definitely fun to go through this. I will say that getting 12 or 13 questions right in a row is kind of atypical for me. There are times where I have stretches where I get like 10 questions wrong in a row or something, so this is a really nice inaugural stream for me. Although I'm very sad you guys did not get to watch me do the first 5 questions, because I felt like I had a good discussion on those ones as well. A 28-year-old woman is evaluated for 2 weeks of intense rectal pain that occurs with most bowel movements. This sounds like, you're saying fissure already. Okay. Yeah, constipation, rectal bleeding, or a hemorrhoid cream didn't work. What is this? Man, I don't even know what I'm looking at here. It's a little polyp by the anus, I guess. Which of the following is the most appropriate next step in management? Anal Botox, flexible sigmoidoscopy, prednisone suppository, sitz baths and psyllium, or topical hydrocortisone and lubiprostone. This is kind of hard. So let's see. Periodic rectal bleeding and occasional constipation symptoms. Hemorrhoid cream did not help. Colon cancer. I don't know what that is. That doesn't look like a fissure to me. That's the only problem here. I just don't know what that is, like some kind of polyp that's coming out. Intense rectal pain with most bowel movements. Periodic rectal bleeding. Like, I almost wonder if this is some kind of weird, like, isn't there those weird, like, Peutz Jeghers, like, polyps syndromes and stuff. I don't think anal Botox is going to be helpful. Flexible sigmoidoscopy seems... All right, you guys, this is going to be my last question. I got to head out after this. So flexible sigmoidoscopy, I kind of want to know because I'm like, what is going on? I don't know what that is. Prednisone suppository, that doesn't sound like something I've really heard of. Sitz baths and cilium, so this is completely like, okay, we just think this is all due to constipation. We'll do sitz baths, cilium, we'll do supportive treatment. That's what you'd be going for here. But I think there's something a little bit more going on here than constipation. And she's been having this rectal bleeding and constipation before her shoulder surgery. And then topical hydrocortisone and lubiprostone, I feel like, you could consider them. Maybe if it's like a really bad hemorrhoid, it could be, but I'm almost going for a flexible sigmoidoscopy, which I feel really bad for because you never want to stick up a tube up somebody's butt when they're having like tons of pain and bleeding. But I kind of want to figure out what's going on here. I wonder if some weird polyposis disease is going on, or is this just really bad hemorrhoids? Is that a prolapsed hemorrhoid? Like, I don't really know what that is. So let's go with that. And I'm wrong. It was just constipation, you guys. I lost the streak on the very last question, but you were right. It was fissure. It is a fissure. See, you know better than the attending, man. You knew from the very, very beginning. So yeah, it is just fissure. Sitz baths and cilium are the most appropriate next step in management. With worsening constipation from opioid analgesic therapy, anal fissures are tears in the anoderm below the dentate line, and they can be seen unaided by the use of an anoscope. Pain with and after defecation. Oh man, I should have known this. So, see, you showed me up. Anal Botox is reserved for chronic anal fissures. Flexible sigmoidoscopy is not indicated because it can be accurately made by just examination. Topical anti-inflammatory could help, but probably less helpful. And then sitz baths and fiber are going to be better than doing topical glucocorticoids. All right. Well, didn't know the answer though. Yeah. Yeah, because fissure, I have some cards on fissures, and I feel like for fissures, there's some other treatments that we use, like you use like nifedipine cream and stuff like that. So pharmacologic treatment of anal fissure. So nifedipine cream, nitroglycerin cream, but then first line before medical management is increased fiber and hydration. So sitz bath is when you just basically get like a little tub and you just have them sit in it, and then increasing that fiber. So that's first line before going to these nifedipine creams and stuff like that. If they had said nifedipine cream or something, I would have been like, oh shoot, Canon Kid was right. There's got to be fissure or something. But I think because it was just like, oh, I thought they were just trying to treat constipation. That's why I was like not too super sure. Most common cause of anal fissure is constipation. And when is surgical management indicated for anal fissure? After medical management fails. First, try fiber, increased fluid intake, stool softeners, sitz baths, and topical anesthetics and vasodilators. All right. Well, that's that for this session. Thanks for watching. I hope you guys enjoyed. I definitely enjoyed interacting with you guys. It's kind of fun doing these kinds of videos while having the chat here, because we can kind of have a conversation about things. Although it does increase the pressure a lot, because I can get some bad streaks sometimes and do pretty badly. But hopefully this is educational for you guys. Hopefully it's fun for you guys to tune in and ask questions. When I'm explaining things, if you want further explanation, this is like a nice way that we can interact a little bit more than my typical videos where you're just watching me and I'm not able to like actually talk with you and interact with you. So thanks again for watching, you guys. I'll see you in the next video, and have a good rest of your day. Thanks for watching, Abradolf, and thanks Canon Kid and Ahmed. Thanks for stopping by. Yeah, good luck for step 2. All right, see ya, Ahmed. All right, see you guys. Peace.